Patients who have very advanced aortic valve disease, who are not candidates for conventional open heart surgery, can have either the transfemoral approach, or if they have peripheral arterial disease on top of that, they can have what is known as the transapical approach directly through the apex of the heart. So we offer all technologies when it comes to heart valve replacement therapy.
Probably about 2 hours. It's a good 45 minutes is set up and getting the lines in. The actual delivery of the valve is about maybe 3 or 4 minutes. But if we're going to go from a transapical approach, you have to gain access to the apex. You make an incision along the rib cage underneath the breast and separate the ribs. And then they put in sutures so that we can put a delivery sheath in that way. Once the delivery sheath is in, it's over within about 10 minutes. They close up the apical hole with the purse string sutures, and then we're basically done. From the femoral, we basically go in with a long sheath, and we have to dilate up the artery to get the big enough sheath in to deliver the valve. Once we get the sheath in, it goes very quickly again, usually within about 10 minutes. So preparation, maybe 45 minutes to an hour. The actual procedure, 10 to 20 minutes. And then closure and everything pulled together, another 10 to 15 minutes. So we look at the vessels, we screen them for size using a CAT scan and see what the size of the vessel is. If it's big enough, then we would do the transfemorally. I mean, really, it's not a question of one better. Really the question is, what can you do? And in the next year, there's going to be a sheath that's about 2/3 of the size that can be done from the femorals, which will make it much easier to deliver. If we cannot get the device up transfemorally, and we try to get it up, if it won't go, then now we can do it transapically in the same sitting.
Using the transapical approach in those patients, which involves a small incision between the ribs, where we take a catheter directly across the bottom of the heart in order to place the valve literally from the inside out rather than the outside in, which is what the transfemoral approach does.
Positioning is much easier from the transapical approach because it's just a very short distance. You move it a centimeter, it moves a centimeter. From the groin, you move it a centimeter, it might not move at all. So it's a little bit not quite as accurate. So you have to be very careful from the femoral artery. I think for the patient, it would still be preferable to do it transfemorally because they don't have any pain in the chest when they get done. So after a transapical procedure, they're still going to have some discomfort where the incision was.
We're exploring ways now to improve the pain management for these patients.
From the groin, for the femoral arteries, basically they might have a little bit of incisional pain, but it's not bad. When the valve is delivered, it's delivered at a heart rate of around 180 to 200 beats per minute, and at that point the heart's just quivering. And then you take a picture with your catheter, the pigtail catheter, to see where that aortic valve is in relationship to the valve, and that's when you inflate it. So the cardiologist would inflate the balloon. Somebody is the team leader. He calls out the instructions for whatever we're going to do. Hold the lungs, pacer on, aortogram, balloon inflation, stopping the pacing. So there's roles for each one of us. We don't have it set up that one person does the same thing every time. We rotate the roles.